Thank you. I think all of you will agree that over the past 2 days we have seen excellent DMAC surgeries, various different surgeons, and all of them have been able to perform the surgery successfully, although the techniques may have some slight variations, but just to show you that it's possible to do a DMAC surgery. So a lot of time people have that mental block of thinking that DMAC is very difficult and it's very difficult to perform. Now, let me just give you a few points that I can share regarding the DMAC surgery, evolution of endothelial keratoplasty from DLEK to DSEK and then to ultra-thin DSEK and DMAC. And I started off with Mark Terry, trained with him in 2004, and I started doing DLEK before moving on to doing DSEK and then to DMAC. So we know that the advantages of DMAC is that you have a faster visual recovery and you have a greater percentage of patients that achieve 20/25 or better. The ideal case selection is important for DMAC surgery. When you start off, I think the Fuchs dystrophy is the best case, but when I tell people who train with me for DMAC surgery, they say, oh, it's the Fuchs dystrophy patient whose expectations are really very high, and if I do this surgery and if I'm not successful, maybe the patient will not be satisfied. So if you don't want to choose the Fuchs dystrophy as your first case, maybe take a simple pseudophakic bullous keratopathy where the anterior segment anatomy is not distorted, you don't have peripheral anterior synechiae, the posterior capsule is intact, and there are no large iris defects. And I think to do an anterior segment OCT and look at the anterior chamber volume, especially the periphery, this is important, and you can plan your surgery accordingly, selecting this case. And once you have done, once you have tasted success with DMAC, you can gradually move on to doing, maybe you want to do a failed graft, or you want to do a phakic eye, or even you can venture out doing vitrectomized eye with IOL exchange. So I think this is something that can be done. It's possible. I know I've seen Gerrit Mellis show videos of doing DMAC in eyes with AC IOLs. I'm not that brave, but I believe that even that can be done. Traditionally, for endothelial keratoplasty, we have been used to, you're fortunate that in rest of the world you have these pre-cut tissues, but back in India, most of the eye banks still do not give us pre-cut tissues, so we have to cut our own tissues. You can use a manual dissection technique using the dissectors, or use the automated microkeratome. Femtosecond laser have been tried, but the interface is much rougher than what you get with the manual or the automated. So what do you do for DMAC surgery? The technique of, there are several techniques, and if you try and master one of them, that would be the great. I use a 10 millimeter trephine, which is 100 microns, so it's a partial depth trephine, so you do a 10 millimeter partial trephination, mark the edges with trypan glue, then use a forceps to partially peel, that's a 70% peel, then you use a 3 millimeter or 2 millimeter trephine to punch out a stromal window, mark the stromal side of the decimate, then go back and do a 8 millimeter central, donor preparation. You can peel off the decimates, and this technique of marking has been from Mark Terry's group, and I think that's really useful. And then we use the trypan blue staining, as you saw in the. Now, for the stripping of the decimates, it's pretty much the same as what you do in DSEK or you do in DMAC. I prefer to keep my pupil dilated because the red reflex helps me visualize the decimates as I am peeled off. Just as you see your capsular axis against the red reflex, you can visualize your decimates as being stripped off. And if you do it, if you're able to retain air in the anterior chamber, I think doing it under air gives you the maximum contrast. So if I have a patient where the corneal edema is significant, maybe I'll resort to putting in an air bubble in the anterior chamber and then do my decimatorexis. Now the problem with the regular Sinski is that the tip, sometimes if you press too much, you will dislodge stromal fibers. So we went ahead and we designed a new DM stripping hook where the tip is like a ball tip, so it's rounded. So even if you press too much, you cannot really disturb the stromal fibers. And I think in DMAC, it's important that your inner surface should be relatively smooth. If you do have irregularities, it can affect the attachment of the decimates, especially when the air bubble is becoming smaller, and you can have this peripheral edge that kind of detaches. What size should be? That's again controversial. Some people make it a little smaller. Some people want to make it a little larger. And even if you do the best centration, you find that your decimates, the donor decimates is not exactly in the area where you have stripped. So sometimes one edge is overlying the area where the decimates is still intact, but I have not seen any increased rate of detachment in the area where it is still present. So you can see this video, we use the tip and we press on the stromal surface. The only disadvantage of this instrument is that if your decimus is fibrous or if it is thick, then sometimes the ball tip DM's hook is not able to break the decimus in one go. You may need to make multiple attempts to try and break. But once you break it, and you can easily strip without having the fear of breaking the stromal fiber. So this is very good when there are people who are starting on endothelial keratoplasty, and sometimes people tend to break the stromal fibers and they are pulling on the stromal fibers thinking that that's the decimus. So once you stain it, there are various ways of loading it into your cartridge. The eye should be soft, and there should not be any external pressure. As you would have seen in my surgery in the morning, the assistant had applied the speculum, so it was really tight. So if you have that kind of external pressure, your tissue can jump out of the eye. So once you put it inside the eye, you secure your wound, and there you see me using a cannula to try and open up the roll, and then you can use the various tapping techniques, and there you see the F mark showing you that it's in the right orientation. If you have an expensive gadget like the intraoperative OCT, you can take the help of that, but I don't think that everybody will be able to afford one in their clinic. Now that's the cannula that has the two side ports at the tip, and the fluid moves laterally. So I find that very useful, and I've ventured out to using donor tissue as young as 28 years old. I'm not worried about them getting into a tight roll because I have this device. So I align it to my paracentesis side, and I go with my cannula. I go inside the tight roll. That's the stromal surface. So once you're reaching the middle part, you give a short burst. The only thing you have to remember is you don't have to withdraw your cannula. You wait for the chamber to shallow. If you withdraw your cannula quickly and the chamber is deep, it's going to again go back in a roll. So sometimes I would even have an instrument externally, and I press the center of the cornea to ensure that the roll that has opened up, it remains open. And once it has opened up, all you have to do is to shallow the chamber to kind of trap the decimus, and then you tap the surface and you can get the decimus to behave the way you want. The only problem when I was transitioning from dissect to DMEC was I was always trying to unfold it, keeping the chamber deep, and I had a tough time, and it would take so much of time to try and tap because it opens up partially, and the moment you deepen the chamber, it would again go into a roll. So you can see there you can see we shallow the chamber. As the fluid goes out, so does the flap tends to open up, and you can see the S stamp there. And you can center it by, so I use a 30 gauge cannula. You make sure that you get one bubble, you don't get fish eggs, because sometimes if you get fish eggs, these small bubbles, they can displace the decimus to the peripheral angle. That's again just to show you another video. I always prefer to suture my wound. Again, you can see that as you shallow the chamber, the one edge of the roll tends to open up, and then you can use two cannula or a single cannula maneuver. You can, the partially part which is opened up, you can stabilize it with one cannula and use the other one like a drum roll to open up. And once it is, you can see there, I want to open that, so I just tap the surface centrally, the fluid waves goes ahead, and it's well centered, and you can, once it is there, you can put in an air bubble, and that's it. Sometimes the DM may get stuck in some part of the iris, and even if it's not exactly in the center, I think it's safe to go ahead and put in your air bubble, because at times, to be very meticulous, you try to move it to the center, and then you realize that maybe the edge has got folded, or sometimes it flips over, and it can make life very difficult. That's how it looks post-operatively. The visual recovery is rapid. And if you see this, this is somewhere on the fourth post-operative day. You can look at the cornea, looks clear, and the dramatic change that you see is in the anterior segment OCT. You see that the corneal thickness really goes down very rapidly. Even by the third post-operative day, you can see that the cornea almost looks like a normal thickness and normal contour. That's a patient who had iris fixated IOL and a corneal decompensation. So we went ahead, removed the iris fixated IOL, did a scleral fixation, and did the DMEC, although at that point of time, it was kind of, that DMEC is very difficult in vitrectomy eyes. You cannot do. There is a problem in terms of you cannot really shallow the chamber, but I think sometimes you have to actually go and aspirate some fluid from the anterior chamber to make it shallow. But you can do that in eyes. This is a patient we operated, 80-year-old with significant epithelial hypertrophy. So we went ahead, phaco IOL and DMEC, and good That's again another vitrectomized eye with scleral fixated IOL. That's a patient did in 2009, and he still comes for a follow-up, very regular with his visit. He's still on topical Lotepred, and you can see that at 7 years follow-up, he still maintains a pretty good unaided vision of 612, improving to 6.6 with correction, and his cell count is about 911, and which is pretty much what I see in my DSEC patient as well. Just to give you why DMAC, why compared to DSEC, studies have shown that it alters the posterior curvature is minimal as compared to DSEC, where you have a much steeper posterior curvature, so no hyperopic shift. This study from Price Group where they had fellow eyes, so I think that's the best situation. When you have one patient in one eye, they have a DSEC, and you do DMAC in the other eye, you have the answer as to what is the quality of vision in the fellow eye, and you see that the cell loss is similar. A lot of people felt that maybe DMAC, because you are manipulating too much, the cell loss is higher, but the cell loss is similar, and you have a greater percentage of patients that see 20/25 or better. Combining it with cataract surgery, DMAC does not alter its outcome. And in terms of rejection, yes, definitely the rates of rejection are much less. And since I started doing my DMAC back in 2009, in my series, I have seen few patients with primary graft failure, but I have yet to see a patient with rejection. And most of my patients are not off steroids, and they still continue with that. So I think one of the greatest advantages, especially for patients who are not very compliant with follow-ups, keeping them on steroids, you have a lesser risk of patients, losing their grafts from rejection. So basically, if you compare DSEC and DMAC, there are differences, just like with extra cap and phacoemulsification. In terms of donor preparation, DMAC is more of a manual technique. The insertion is basically no-touch fluid-based, unlike you have the various inserter systems for DSEC. Unfolding, in DSEC, you require an AC maintainer, maybe a deep anterior chamber. In DMAC, it's a shallow chamber. And the air bubble in DSEC, maybe even if you remove the air bubble after half an hour or 45 minutes, it will still stick. But in DMAC, you need to keep it for 2 to 3 days. So DMAC looks great. It has a faster visual recovery, better quality of vision, no refractive shift. So if you're doing a triple procedure, maybe your refractive outcome is much better. Reduced risk of endothelial rejection, and the endothelial cell loss is similar to DSEC. So I think that's the reason why I try and do DMAC as far as possible. Thank you.